many of us see that there's a clinical spectrum that's still different. There are men who have a more indolent course with their prostate cancer, and then there are men who very clearly have very aggressive forms of prostate cancer and progress rapidly through androgen deprivation, abiraterone, enzalutamide, and that there really is still a role for approaching these patients with very aggressive therapy. So again, I've kind of gone through the historical use in castrate-resistant prostate cancer for chemotherapy and the idea that sometimes we may want to delay chemotherapy further. But then some investigators started to ask, is there a role for perhaps giving upfront chemotherapy? Could we improve the outcomes with chemotherapy if we used it even earlier in the disease course? And there are a few good reasons for this. So one theory is that chemo may be more beneficial when used to treat small volume disease. This is kind of a cartoon that I've made about, basically, if you think about a tumor itself is a heterogeneous mass of cells. And there's some theory that at the time of metastatic progression, a tumor that forms may have some isolated stem cells within it that are already castrate resistant. And that by treating men with androgen deprivation for a long duration, essentially all we're doing is treating the castrate sensitive clones and sort of selecting for the castrate resistant stem cell, which then will go on to give rise to more aggressive metastatic progression. And so this idea that giving chemotherapy earlier may eliminate these androgen insensitive clones when it's at a very small volume, which is the best chance we have to control the disease. And so that led to a number of studies. There have actually been a couple. There's the Stampede trial, which had enrolled in the UK. There was a French study. And then there was the Chardon study, which was the US intergroup trial. It was a cooperative group study. We come up with great names for our trials in oncology. So this was the chemohormonal therapy versus androgen ablation, randomized trial for extensive disease in prostate cancer. Very clearly becomes charted. So how was this trial designed? So they randomized close to 800 men, randomized 1-to-1. Men were either treated, these are men with de novo metastatic disease, treated with either androgen deprivation alone, and that could be GnRH as monotherapy, or they could have been getting complete androgen blockade, or they were treated with androgen deprivation plus 6 cycles of chemotherapy. And again, it's important to note that this is a definitive 6 cycles and then they're done. So that's a little different than how we use chemotherapy, again, for castrate-resistant disease, in which we treat men with chemotherapy until they progress. And men may get, like I said, 8, 10, 12 cycles of chemotherapy. So in this case, it was a limited amount of chemotherapy. When we look at trials like this, we look to see, well, how many men really did complete the planned course of treatment? And it was pretty good. So kind of suggests that tolerance was good. Nearly 90% of men who were randomized to that group did ultimately complete the treatment as planned. And the investigators were looking at, their primary goal was to see if this improved survival. Their secondary goals were to look at other things, changes in PSA, quality of life measures, the time to developing castrate-resistant disease, time to having clinical or symptomatic progression, et cetera. And when we look at the patients who were enrolled on this study, we see that the median age was 63, which is pretty typical for prostate cancer. The range was quite broad, so the oldest patient enrolled in this trial was 91 years old, so it just shows that we don't kind of use age to necessarily exclude somebody as being eligible for chemotherapy. It's more about their performance status and fitness. And it's true that the majority of men on this trial had very good performance status. So a performance status of 1 suggests that they have very minimal disease-related symptoms. They're up and around and mostly active during the day. About 3/4 of these patients had not had any prior therapy. So again, these were men who presented, their first diagnosis of prostate cancer was metastatic disease. 1/4 of the patients had gone through localized disease first, with about 20% of them having received a primary prostatectomy for their definitive treatment, and 7% having received primary radiotherapy. And they had to start their chemotherapy within 4 months after starting their initial GnRH medical castration therapy. Also important to note is that in the patient population, the investigators started with a pre-planned analysis based on metastatic burden. So these men were randomized or were analyzed in groups according to their volume of disease. So high volume disease was defined as men who had greater than 4 sites of skeletal metastases with at least 1 outside the spine or the pelvis. And then they were also considered to be high volume diseases. They had visceral metastases. So that's mets to the liver, mets to the lung, mets to the brain. And those are all kind of, again, I alluded to that phenotype where we see that men may have more aggressive disease. And these definitions, visceral metastatic disease or diffuse innumerable bone metastases, these are patients who we imagine are going to have a more aggressive course. And everybody who didn't fit into the high volume group was, of course, considered low volume disease. So they did find that with chemotherapy, there were significant improvements in the number of patients who achieved a PSA of less than 0.2 at the 1-year time mark, which was thought to kind of translate also into disease control. And then they did see an improvement in the time to progression. But the reason that this study is so exciting and why it is a landmark for us in medical oncology is really looking at the overall survival advantages. So this green line here is the chemotherapy plus androgen deprivation arm. The blue line is androgen deprivation alone. This is the Kaplan-Meier survival curve for all patients enrolled on the study. And what they saw in this case was that the median overall survival increased from about 44 months for men who started out by just getting their androgen deprivation to about 57 months. So that's a 13 and a half month improvement in survival. And again, when we compare to those treatments that we use in the castrate-resistant setting, where the advantage is even to chemotherapy in that setting, we're talking about 3 to 4 months benefit versus 13, 14 months benefit, and with less chemotherapy in this space. And even more impressively, they did an analysis by volume of disease. And it's clear, this table on this graph on the left is the high volume patients. These were the patients who had the most significant benefit so far. The patients on the right in the low volume disease, the average or median overall survival hasn't been reached yet, which again speaks to the fact that those patients tend to have a more indolent disease course. And so in the first 5 or 6 years of follow-up, we haven't yet reached median overall survival. But as more patients, as time goes on and more patients die, we may see that these curves separate, but the jury's still out on that. Numbers-wise, this is just the same data kind of in table form, again, to kind of drive home the point that survival advantage was significant in all comers, but then in high volume disease specifically, the median overall survival increased from 32 to 49 months. So that's a 17-month survival advantage. So finally, we have a treatment that improves survival by more than a year and a half. And again, giving less chemotherapy than these men would otherwise have been exposed to in the later lines of therapy. And so for that reason, this really has changed our practice in the way we treat men with high volume metastatic disease. So the conclusions, is, as I've hopefully made clear, is that chemotherapy use in hormone-sensitive prostate cancer for men that are carefully selected does improve survival over hormone therapy alone. It should absolutely be considered for men with high volume disease. I'm always happy, and I'm sure that your medical oncologists that urologists work with, et cetera, are happy to see these patients and counsel them on the potential pros and cons of getting chemotherapy. It's of course always up to the patient, but we feel like this is a really significant stride in how we manage these patients and should be considered for men with high volume disease. For men, yes, please.
I had one question. The statistics that you get on the chart about that 73% of them metastatic.
Yes, right. Correct.
I wonder if that's being linked with the changes in PSA screening.
So when the trial was enrolling, so this trial started its enrollment in the early 2000s. So I don't think it's really at this point linked to recent USPSTF guidelines as far as screening. I think it was more by virtue of the fact that the trial was aimed at looking, of course, at men with high volume metastatic disease who we thought had aggressive courses. And so a lot of times those are men who've presented without a kind of prodrome of having had their prostate cancer diagnosed at an earlier stage. It raises the question, though, which I have here on the bottom of the slide, which is this group of patients is a small subset in the grand scheme of men with prostate cancer, although as you've already raised, we may start to see more and more men who are unfortunately diagnosed in the metastatic setting. But how do we extrapolate for those patients who've already been treated? I would say that, for me, if I'd seen a patient who had been definitively treated a few years back and then unfortunately had a metastatic relapse, if they meet the criteria according to this study, I would still offer those patients early chemotherapy, simply because there is a likelihood that these patients will be treated with chemotherapy, with Taxotere specifically, at some point in their disease course. And so if they have a very aggressive histology, on their pathology, on their biopsies, or if they've, rapidly relapsed or they have widespread disease, then I'm likely to offer them chemotherapy early. And just as I was starting to say, and I kind of hit home, is that long-term follow-up is needed for men with low volume disease. For those patients, the risks of giving early chemotherapy may not outweigh the benefits, and so we still need more data to kind of determine. So right now we're not routinely offering this approach for men who have 1 or 2 sites of metastatic disease. So I think, kind of looking at our table of the prostate cancer trajectory, I think there's a clear role here for this early chemotherapy approach kind of fitting in along this spectrum of options that we have now. So if early chemotherapy for metastatic patients is better, then maybe giving chemotherapy for non-metastatic patients is best or even better. And so I'm going to talk a little bit about some of the trials that have been evaluating this approach as well. For chemotherapy in non-metastatic prostate cancer, this is a little bit more of a difficult situation to grapple with because we have men who are cured with definitive therapies, surgery or radiation therapy, and giving chemotherapy might improve outcomes, but potentially we're introducing toxicity to a large population of men who may not have needed it. But at the same time, we know that high-risk localized prostate cancer has a relatively poor prognosis, again, compared with men with low-risk localized prostate cancer, with relapse rates anywhere between 15 to 20% over a 5 to 10 year period. And so if we could improve those outcomes, then of course we would be saving lives, and I think we can all agree that that is worthwhile. So a few trials have started to try to look at this question, again, specifically in high-risk populations. So high risk we would define as men who have high local T stages, high Gleason scores, and elevated PSAs. Of course, men who have node-positive disease are also considered to be high risk. So this first publication, this is a trial out of the French group, the GTUG 12 study, which looked at localized high-risk prostate cancers and looked at improvements in relapse-free survival was the endpoint that they wanted to see. But in this trial, men were randomized to androgen deprivation for a 3-year period versus androgen deprivation plus docetaxel chemotherapy, which we use here, and estramustine, which is a chemotherapy that they use more in Europe for men with prostate cancer, and we don't typically use as much in the United States. And interestingly, the way they treat these patients, about 3/4 of them did also get definitive radiotherapy, but not everybody did. So they did have men who had high-risk localized prostate cancer who were treated with systemic therapy alone, which is a little bit less common here, I would say. They looked at the primary endpoint of relapse-free survival. As I mentioned, they've had median follow-up of close to 9 years at this point, and the 8-year relapse-free survival was improved in the chemotherapy group. But I think at this point, longer follow-up really is still needed. We don't yet know if there's a metastasis-free survival advantage. We don't know if there's an overall survival advantage. And again, when we're weighing the risks and benefits of giving men chemotherapy, if it's not going to help them live longer or not going to make a very significant clinical change in their disease course, then it may not be worth the potential toxicity. More recently, we've had in the United States, we had a presentation at our ASCO meeting in 2015 of a radiation-driven trial. So this is the RTOG 0521. And I missed Matt's early slides on prostate cancer, so I don't know if he talked a little bit about this approach or not. May not have gotten into it. But this was a very provocative abstract that was presented at that meeting. It was a phase 3 protocol looking at androgen suppression and radiotherapy versus androgen suppression radiotherapy and followed by chemotherapy. And that chemotherapy was docetaxel, and this was again for men with high risk localized prostate cancer, which you can see here they defined again with men who had very high Gleason scores, or men with intermediate Gleason but high PSA, or men with high T stages and also high Gleason regardless of the PSA. And the randomization is here, again, kind of standard radiation plus extended androgen deprivation, which is usually given for about 2 years, versus that same approach plus 6 cycles, again, of chemotherapy starting about a month after the radiation finished. And what's interesting about this trial, and the authors this is why they were invited to present, they looked at disease-free survival, and they did show an advantage. So this red line is the chemotherapy group. So there was a significant improvement in, again, disease-free survival 65% with chemotherapy versus 55% without. They showed a statistically significant benefit in the occurrence of distant metastases. And they showed a statistically significant benefit in overall survival. So these curves are separated, and that is a statistical benefit, but I think many of us feel, as we look at this data, that we're not quite ready to hang our hat on this approach. And that's because this was a 4-year overall survival that they looked at. In the chemotherapy group, that 4-year overall survival was 93% of men, so that's terrific. In men, though, who got simply the standard approach, we still cured about 89% of those men at a 4-year follow-up. Over time, these curves may separate further, and we may see that chemotherapy is really worthwhile, but I think many of us feel that a 4% increase, that the absolute benefit there is still fairly small, and that we may not be ready to recommend chemotherapy to all of these patients. We are also looking at the approach of using chemotherapy as neoadjuvant therapy prior to prostatectomy. So what happens, can chemotherapy improve our surgical outcomes as well? So this is another cooperative group trial. These patients were randomized, again, chemotherapy. This is the same approach that we've been seeing, 6 cycles of chemotherapy given with the GnRH therapy pre-operatively, and then men go on to have their radical prostatectomy, or they just go straight to radical prostatectomy. This trial just completed enrollment in December. We had it open at Loyola, and I have a few patients on the trial. They have really remarkable responses in their PSA with the chemotherapy, as you might expect. These are men who have an elevated PSA. They get 1 or 2 cycles of chemo, and PSA already drops close to 0. But the question is whether or not that's going to translate into improved outcomes, of course, compared to surgery alone, or if we're just exposing men to excess toxicity. So jury definitely still out on that, but I think, hopefully within the next 5 years or so, we'll have some data from this maturing. So I think in this setting, in men with non-metastatic disease, certainly we know that androgen deprivation remains central in the management of high-risk prostate cancer, concurrently with radiation specifically, or again, in Europe, they're using androgen deprivation to treat these men because they're at high risk for metastatic recurrences. But really, the risk-benefit ratio needs to be considered. In that RTOG, the radiation trial that I showed you, there were technically more deaths in the non-chemotherapy group. But in the chemotherapy group, there were 6 deaths that people feel are somewhat concerning. 2 deaths were attributed to chemotherapy. 4 deaths were given kind of an unknown designation. And again, if these are men where close to 90% of them would be cured without that potential risk, then we're exposing men not only to the toxicity of chemotherapy, but potentially a chance that they could have a life-threatening complication from chemotherapy that they may not have ever needed. So we'll wait for more data in this setting. Most likely chemotherapy will play a role in very carefully selected patients, men who have very high-risk disease and may be very young, where you expect their life expectancy to be long. Those might be patients that we counsel on this approach. I have had a couple of patients who we've talked about this option. None of them have really gone for chemotherapy, and I confess I haven't been pushing it as a really attractive option for my patients at this point. So we'll see how this develops over time.